Thank you, everyone, for coming to Pediatric Grand Rounds. I have the distinct pleasure of introducing Dr. Bob Opoka. Bob and I go back a long way, as he will tell you in the talk. We've been working together for 11 or 12 years, actually. And I just wanted to share some things about Bob that other people don't know that might surprise you. So when we first met him, he was walking around with a pediatric Harriet Lane in Mandarin Chinese. And we said, wow, Bob. So it turned out that he had just come back from completing his pediatric residency in China. He delivered the valedictory address for his residency class in fluent Mandarin Chinese. So not only is he a brilliant pediatrician, but he can sort of do almost anything. The Chinese stuff blew us away, and we like taking him to Chinese restaurants because he can kind of shock people by knowing what they're saying when they're talking behind his back and stuff. So Bob, as I mentioned, is a pediatrician at Malaria University. He's also an adjunct assistant professor with our global pediatrics program here. And he is an expert on severe malaria and is actually an expert on treatment of severe disease in children across the board. Has become quite well known for that across African institutions. Has done a number of talks on that, published a paper in the New England Journal of Medicine on fluid expansion trials. But his work with us is focused on severe malaria, and that's what he's going to talk about today. It's really fun to see him give this talk because it's fun to see how things grew from a small initial project to a bunch of projects. And Bob has essentially been co-PI on all of this project, so a lot of this is due to his work. So welcome, Bob, and thank you.
Thank you. Good afternoon. I'm very honored to be able to share with you this talk. I'm going to talk about the Malaria University, University of Minnesota collaboration that we have been doing for the last 11 years. Our topic has been really severe malaria. I'll share with you what we have learned over the 11 years of work. I prepared this talk in Chinese. I don't know whether I'm allowed to give it in Chinese. Maybe not. English. Okay. So I'll talk really about severe malaria and just tell you why it matters and to give you a background of why we did what we did in severe malaria. And then, of course, I'll talk about our first research study that we did with Chandi and my other colleagues, and then how this study led to other studies in a similar area. And finally, I'll tell you where we are now and what we are planning to do going forward. So, malaria is, outside here, is a major public health problem. It affects more than 90 countries worldwide. WHO estimates that maybe about more than 240 million cases are reported worldwide. Okay, and accounts for an estimated 863,000 deaths, the majority of which actually happen in Africa. So in Africa, where I come from, malaria is a big problem. This is the map of the malaria. And as you can see, that it really affects mainly sub-Saharan Africa, where it is a very serious problem. So just as a background, so what really is malaria? What is malaria really? Just to complete the talk, malaria is a protozoan disease that is caused by infection by Plasmodium species. It is transmitted from person to person by the bite of a female Anopheles mosquito. Right now there are 4 species. There are actually 5, but the 4 common ones. The most severe one is falciparum, P. falciparum, which manifests a variety of disease, ranging from just a symptomatic, symptomless infection. People can just be carriers of malaria, and up to about 25% of children in malaria endemic areas are just carriers of malaria without having any problem, to very severe disease. And for this talk, I'll be talking really more about the severe form of malaria. But for you to know that it can cause anything, right, ranging from a mild disease to a very severe disease. In Uganda, malaria is a big problem in Uganda. It's a major public health problem in Uganda. It accounts for up to 40% of our outpatient attendances and about 20% of our admissions, and the leading cause of death in children under 5. And it takes up about 10% of the household income. So it has a big economic impact in the country. Children under 5 are the most vulnerable people to severe malaria. Other people who are vulnerable to malaria include people who have sickle cell disease, those living with HIV/AIDS, pregnant women, especially women doing their first pregnancies, and travelers from non-endemic areas like people from here. So if you come to Uganda, please make sure you take your malaria prophylaxis. If you got it from there, it will be very serious. So it's a big problem in Uganda. And why is it a problem in Uganda? A number of reasons why it's a problem. One, we have a nice climate in Uganda. It is warm and cozy throughout the year, which is good for us, but also good for the mosquitoes. You know, it provides a perfect weather for the mosquitoes, and therefore we have a very high burden of mosquitoes. It's a high density, they're very efficient, and they're very virulent in Uganda. And also we have a lot of resistance both to the mosquitoes and also to the malaria parasites. That has been a big problem. We have issues with immunity because of the burden of malaria in the community. Children under 5 don't have immunity to it, and that's why they are very prone to it. Those with sickle cell anemia are also prone to it. The women who are giving birth for the first time are prone to it. So there are issues with immunity, and there are also issues with the health service. So all of these work together to contribute to the high burden of malaria in our setting. So we really have a big problem of malaria in Uganda. How does it present? I've already told you that it characteristically presents with a fever and other clinical features. And I've already shared with you that can be just a symptomless parasitemia or can have very severe disease. And I'll talk more, and I'm going to concentrate mainly right now on the severe manifestations of malaria. So severe malaria really presents like a febrile illness. So you get a febrile illness. When you do a blood slide, you get plasmodium in the slide and a number of clinical manifestations, which might be clinical or laboratory. So a febrile illness, a positive blood film for malaria parasites, and any number of manifestations. And these are that. I know you can see this. So it can range from cerebral malaria, severe anemia, acute renal failure. So any of these manifestations make it severe malaria. And children can have just one, or sometimes they have a combination of them. And that makes it very, 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 very severe. So any of these manifestations make it severe malaria, and these are clinical. You can also have laboratory manifestations, so you could have prostration. So any of those makes it severe malaria. And they're actually grouped that not all of them have the same risk to life. They are grouped into 3. Some are more dangerous than others. The most dangerous ones are severe cerebral malaria, respiratory distress, hypoglycemia. There's another group which has moderate risk to death, and another group which has low risk to death. So although they're all severe malaria, it depends on the manifestation you get. Some manifestations have a higher risk than others. And for our talk, we shall be concentrating mainly on this one, which is actually the most severe form of severe malaria. And then this one, which is the most common form of severe malaria. So cerebral malaria. So this is how cerebral malaria presents normally. It's common in children under 5, like I told you. And they come in, typically they come in when they're in coma. They come in with a lot of neurological complications. This child is having this staring gaze, is having feasting, is having scissoring of the leg, is having posturing. They might also have convulsion. So they come in when they're very, very sick. It's a very severe manifestation. And even with treatment, the case fatality rate is very, very high. Up to about 18% of them die, even with treatment. Okay. But the thing about cerebral malaria is that those who survive make a Lazarus-like recovery. So the mother comes with this child who is almost dead, okay? And then you give treatment. If they wake up, they actually do wake up, begin to talk, begin to eat, begin to play, and are good to go home in 5 or 7 days, completely, apparently well, which is such a dramatic and remarkable recovery, okay? So and that is quite satisfying for us, the clinician, because if you treat this child well until he wakes up, it is dramatic. The mother will not forget you, and you probably not forget the child as well, because it is such a dramatic recovery, okay? And previously it was thought that these children make complete recovery, that those who recover have recovered, they are okay, there's no problem, okay? And this actually was the basis of our study, that we asked ourselves, do those who recover really recover? Do they make a complete recovery? Is there no problem? Is it happy there ever after? That was the question that we asked. So this is how the cerebral malaria project came in. Our interest was that severe form of malaria, and I'm going to tell you now how we came in and how the severe malaria project came to be. So, of course, this is what happens in Uganda. For those of you who may be geographical challenged, Uganda is in Africa. It's not in West Africa. It is right here in the middle of Africa, right across the equator. This is the Nile. This is Lake Victoria, the biggest lake in Africa. It has the river Nile, which flows all the way up to Egypt. So this is where Uganda is. Beautiful country. We have the mountain gorilla, which is the only surviving place. We have the source of the equator. This is John Pierre. John Pierre was our first, one of our first research drivers, assistant. We have beautiful landscape, beautiful countryside. We have the snow-peaked mountain. We have the birds. 67% of all birds found in Africa are found in Uganda. It's a place you need to come and visit. It's a place you need to come and visit. The actual part. You're welcome to Uganda. Okay, I digress. So the severe malaria project. So in 2003, this was me when I was, many years back. So in 2003, Chani first came to Uganda in 2001, and his interest was doing highland. He was interested in highland malaria, and so when he came to Uganda, he teamed up with the team in Uganda, and with Michael Boivin, who was at that time from Indiana Wesleyan, but now he's in Michigan University, who had got a Fulbright scholarship worth $5,000 US to come and look at to describe the cognitive problems that are associated with malaria. I just finished my racing at that time. I was come back from China. I was working as a translator in a construction company, and that's how I joined the team. So our first study will happen in Mulago Hospital. This is the pediatric ward in Mulago Hospital in Uganda. And the aim of that study, which became an RO1, was to describe really the neurocognitive outcomes of cerebral malaria in Ugandan children. Like I said, initially it was thought that children make a complete recovery, and our question was, is that actually true? Okay, and to identify if any clinical or immunological correlates to these outcomes. So that was the aim of our study. At that time, it was a small R21 study. And what happened was that we recruited children who were 18 months to 12 years. We did a cohort. We had a cohort of children with cerebral malaria, another cohort with uncomplicated malaria. These are children who have malaria, just a febrile illness, but no other complications. And from the families of these two groups of children, we recruited healthy controls, siblings from the similar environment. And we followed them up for up to 24 months, okay, and did visit at 0, 3, 6, and 12 months to follow up these children and see how they progress after cerebral malaria. We measured, we did blood work at enrollment, we did a neurological exam at all the time intervals, and we did this cognitive test, a battery of cognitive tests to see what happened to their memory, learning, and their attention. Do these children make a complete recovery? This is one of our, this was one of our co-investigators. Is called Paul. He has since gone on to become the first African to have a PhD in neuropsychological assessments. At that time he was just out of school, and they're working in my room. This was my office, which was both my office. It was the clinic. It was everything. This small space, small space. You can see my books are here. This is where I sit during the day, and in the afternoon they do these tests from that room. Okay, so this is how it began in 2003. Okay, so what did we find? So we published our paper in 2007. So what did we find? So what we actually found was astonishing. That at 3 months, if you look at this, this is impairment. 19% of them at 3 months had some form of cognitive impairment. That is, their attention, their learning, their memory was not as good as compared to the healthy community controls, and it kind of kept on increasing. At 3 months it was 19, at 6 months it was 21, and at 2 years up to about 25% of them. So really 1 in 4 CM survivors have long-term cognitive impairments. Okay, so this is what we found at that time, and then that raised a lot of questions. So okay, so what causes this impairment in these children? So it's not true that when they recover, they actually recover. So what causes these impairments in these children? And is it the same? Is it the same for all severe forms of malaria, or just for cerebral malaria? And can anything be done to prevent this? Okay, can these deficits be treated? So more questions led to more proposals, and we were able to get funding for a bigger study, an R01, to look at it in a bigger way, and to define markers of these impairments, and to establish the areas where these impairments take place. Okay, so we got this at R01, and from around 2008, we just finished in 2013, we did this bigger study using the same thing, and we're able to report it this year, report our finding this year. And what did we find? In terms of what predicts these outcomes, we found that coma duration after admission, seizures during hospitalization, and neurological deficits were associated with these deficits. But the big finding was this: in terms of ability. So this is the the healthy community controls. These are children with severe malaria anemia, and these are children with cerebral malaria. And you find that this should be your baseline, and you find that there's a lot of deficits in cognitive ability for cerebral malaria compared to the healthy community controls. Okay, but what was striking was that even children with severe malaria anemia, also had these deficits. Okay, and the mean difference is equal to about 14-point IQ difference. Meaning that if you have cerebral malaria, and in many children in our country have cerebral malaria, even when you survive, your level of cognition is 14 times worse, and therefore your achievement in life, your lifetime achievement is going to be much diminished. So you are really, it's a very bad thing to have. But surprisingly, even those who have severe anemia, which condition is not really has anything necessarily to do with the CNS, also having cognitive deficits. Okay, and it looks like it is different because if you look at the attention, if you look at attention, severe malaria anemia kind of is not as bad, if you look at memory, so for attention, severe malaria anemia is equally bad. But for memory, it does not affect memory in severe malaria anemia very much. So meaning that there are probably different mechanisms involved in these different manifestations of severe malaria. So although it is one disease, as you can see, it's very complex. It presents probably having different pathology for different manifestations. Okay, but the big point was that severe malaria anemia also were affected, although it should not be having any problem with the CNS. So our question there was that, therefore, that so does other forms of severe malaria rather than CM or SMA also have problems with cognition after malaria, and which is the focus of our present RO1. So as most has now led to 2 RO1s. Right now we are looking at all severe malaria and following them up after hospitalization to see whether these deficits are actually also present in other forms of severe malaria. Okay, but most importantly, what we have also found that there are many things about severe malaria anemia. And this is where I want to talk about what I want to talk about for now in the next few slides. So severe malaria anemia is one of the severe manifestations of severe malaria, as I told you about. It presents typically with low HB, defined by WHO as HB less than 5 grams per deciliter, and often requires a blood transfusion. Okay, so it is one of the most common indications for blood transfusion in children in our settings. Okay. And it's the most common form of severe malaria. It accounts for about 64% of all forms of severe malaria is actually severe malaria anemia. Cerebral malaria accounts for only about 20%, but it's because it's very severe. People are very more interested about it. But the more common presentation actually is severe malaria anemia. And because of the big numbers, almost few percent of all malaria deaths are due to severe malaria anemia. Okay, and after discharge, after transfusion, patients definitely require iron therapy for their treatment. And when we followed up these patients over 6 months, we actually found that after discharge from hospital, so the green plots are shown with severe malaria anemia, the blue ones are shown with cerebral malaria, and the red one is the community healthy control. After discharge, at 6 months after discharge, the children who have severe malaria anemia many of them require to be hospitalized again. Many of them come back for readmission after discharge, more than children who have severe cerebral malaria and children who have healthy community controls. And also many of them actually die after hospitalization. So although they kind of recover, their post-discharge outcomes are quite poor. Okay, their post-discharge outcomes are quite poor, and this is something that we are working on to see why is this the case, and what could be the factors associated with this. Okay. So this is what we have found, and this finding actually correlate with other findings from other studies done in Africa about children who recover from severe malaria anemia, and these are like almost incidental findings, because remember our focus initially was cerebral malaria, and because this was a comparison group, we've made this interesting discovery, and we're now trying to follow it up as well. And so because of this, something has to be done about them, because they have a higher risk of hospitalization and death post-discharge. There has to be some kind of intervention, and right now we are looking at doing another study trying to intervene in this group as well, and as well as trying to understand why they find this. So right now we're doing an intervention study to see whether chemoprophylaxis in the immediate post-discharge period after discharge can improve the outcome. And this study is about to begin in many centers. It's a multi-center trial. And we're also trying to look at why do they have this recurrent hospitalization and death. That's the focus of a PhD thesis, which we're about to begin doing shortly. But the thing I want to talk about right now is the iron therapy. that children who have severe malaria, because of the low HB, they're often also iron deficient, and WHO recommended that they should begin to be given iron therapy after the blood transfusion. So presently, but what happened was that iron in malaria is not necessarily a good thing, because there's this study which was done in Zanzibar, which found that if you give iron to children who have malaria, you actually increase malaria, because the parasites also need the iron. It's good for the parasites. And so right now there's a lot of debate on when to give iron. Should we give iron? Should we give iron? Okay. And WHO recommends that all children who finish the blood transfusion should get iron, and they should give it for 3 months. Okay. And this is the dose. They should give for 3 months, and this is the dose. So this is the present recommendation right now. Okay. So because of this, we decided to look at this topic as well and to do some studies on this. And we are doing 2 studies. The first study is called acute versus delayed iron therapy, and what's the effect of progression on this. Whereby we're emphasizing that if we delay giving iron for 4 weeks, that may maybe improve the outcome, because people think that immediately after the presentation there's a lot of inflammation, which may affect the absorption of iron and therefore the uptake of iron, and so we are hypothesizing that giving it after 4 weeks, when the inflammation has settled down, might actually ensure may actually ensure more optimal uptake of the iron and therefore better outcomes. Okay. And what we did was to investigate this. So the objective was to investigate the effect of the immediate versus delayed iron treatment on the status of anemia and its effect on subsequent malaria, and to see whether this affects behavior. And because when you have a big study like the other one we have, then you're able to nest a number of studies on it. So this study was nested in on our cohorts. So this is the iron study, and this is the malaria study. And so at enrollment, children who have severe malaria anemia, we look at the iron status, and we randomize them to either get iron immediately or after 1 month. And then we follow them up for 12 months. Along the way, we're getting their iron status at admission, at 6 months, at 12 months. Okay? And so this is what we're doing for our studies. The other thing we're doing is we have also another study which we're looking at, and we're saying that is the absorption better if you delay it. Okay? So the first one was looking at really the overall effect on the child, but about the absorption. So if you give it after 4 weeks, is the red cell incorporation greater? And so we have an isotope which we are using that you can almost measure its uptake in the red cells. And so what we're doing for this study is we have 100 children whom we're randomizing to get their iron on day 0, or to come and get it at 28 days, which is 4 weeks. And we are giving an iron isotope, which you can then demonstrate its absorption. Okay. So these studies have begun. They're actually nearly finished. We have got the results, but we are still analyzing the results, and so I cannot present the results at this point. But something to look out for. So you can say one study has led to another and has really made us grow. Okay. The last study I want to talk about is apart from just malaria, anemia also is caused by sickle cell in Uganda. We have sickle cell disease is a hemoglobinuropathy, which is a congenital inherited disease, and it's actually quite frequent in Caucasian. I mean in African Americans, and especially in Africa. So it's very frequent in malaria endemic areas, up to about 300,000 children are born with it every year in Africa. In Uganda, we have about 20,000 children born with sickle cell anemia. Unfortunately, a staggering 80% of them die before their 50th birthday. So it's a big problem. And when you have malaria, malaria increases mortality in children who have sicklers. You could have sickle cell anemia, or you could have sickle cell trait. It's believed that sickle cell trait, they are resistant to malaria. But those who have the sickle cell, who have the homozygous state, actually when they get malaria, they have a higher mortality. Confident hydroxyurea has been shown in non-malaria areas to decrease on pain crisis, hospitalization, and transfusions in non-malaria areas. But in malaria settings, we don't know what hydroxyurea could do, because hydroxyurea also increases ICAM. These are endothelial factors, ICAM1 and 10 alpha. It increases their concentration, and these have also been identified to be important risk factors for severe malaria. And so by increasing these cytokines, it could also potentially increase mortality in children in malaria, in children who are sicklers. At the same time, hydroxyurea actually increases fetal hemoglobin, which could actually decrease malaria risk. So right now there's a lot of we don't know what it can do in the malaria endemic area. There's equipoise. Okay, and so what will be the risk of giving hydroxyurea in malaria endemic areas? And this is this our new study which we are doing right now. And so we have a randomized double-blinded placebo-controlled trial where we hope to enroll 200 patients who are homozygous for sickle cell disease, randomize them to get either hydroxyurea or get a placebo, and follow them up for 12 months, and evaluate the incidence of malaria, the frequency of toxicities, and any subsequent factors associated with that. Okay. At the end of the study, we're going to open it up and give every child who participated by hydroxyurea, because it has been shown to be important. Okay. So as I've told you that you found one small study which you began, the Fulbright study, led to the R21 study, and then this led to other studies, the big CM study, and many other studies have come out of that. Okay, many other studies have come out of that, intervention studies. Yeah, because of time, I won't go into that. But many aspects have come out of that because of one study, and this has been the story of our collaboration with the universities. Right now, actually, we have 14 studies ongoing. Someone talking about the CCRT study, which is here, which came as an intervention, because these children who have these cognitive deficits, and the question was, what do we do with them? And we have a computerized cognitive rehabilitation therapy, which we piloted and tried to see whether giving these children computer programs to play with would improve their outcomes. I've pressed something. I don't know what I've pressed. Okay, and someone is here who was part of that, and so we did a computerized. So we had a pilot study and did a computerized cognitive rehabilitation therapy, and we're trying to see whether giving them some computerized programs can actually improve their cognition, and the results of this have actually been very promising. And something that we're working on, but I can't talk about that now because of time. Okay. We have also tried to see whether giving inhaled nitric oxide could improve outcomes in children who have severe malaria. So the one study which began in 2003 has led to a number of. Right now we have 14 studies ongoing. Okay. So from the one study, we have got 14 grants, including several NIH-funded projects. We have had a number of publications. We have up to 40 publications in peer-reviewed journals. We have had over 50 conference abstracts and talks just from our study. So it has worked out to become more than we actually expected. We have had several students train and qualify and progress through the years. We've had several who have done their PhDs and finished. I talked about Paul. We have had several who have done the MSCs and finished, both local and internationals. Right now we have a D43 training grant ongoing and a Doris Duke student program. Right now we have 3 students on this program on campus in Uganda right now. And we have a D43 training grant ongoing. We hope to train 4 PhDs and 4 PhD students and 6 master students from the D training grant. So the collaboration has really grown, and many people have been involved. We have built capacity, both local and institution. For my small room that I showed you at the beginning, now we have several offices, including a lab space. We have even administrators. We have even other sites that we work in, apart from just in Uganda. We've had several students and faculty exchanges from Minnesota and Makerere. We now have about 2 of us who are adjunct faculty in Minnesota, and we have had several students from here, especially those on the global track, go to Uganda and spend from a few weeks to up to a year in Uganda. We have expanded the collaboration to include other collaborators. We now have collaborators from Michigan University, Cincinnati, from the Royal College of Pediatric and Child Health in London, from the Norwegian Research Council, and so we have moved as we have had more studies to do. And where has this collaboration worked? We have had great collaborators. Really, we have had people we have been very fortunate to work with people like Chandi, who have really been great collaborators. We've had people who are very passionate about their work for global health, for child health. We've had a clear focus of research. Our area was cerebral malaria, which is a problem in Uganda, and we have now expanded to include things like severe malaria anemia and sickle cell disease. These are really problems which affect the children in Uganda very, very, very strongly. We have had trust from our collaborators to work with us and to trust us to deliver for them, and they've also trusted us to work for them in Uganda. And that has really helped. We've had clear roles. We have a PI here and a co-PI there who runs study on the ground and collaborates very well with the PI from here. I've been the main collaborator for Chandi John, and our other collaborators from the other universities also have other collaborators in Uganda. So this has really worked very well. And so this has come towards the end. These are the key collaborators. Chandi has been our key collaborator here in the university. Here. This is Michael Boyvin from Michigan, who has been a key collaborator, doing mainly is a neuropsychologist. So he has been handling many of the neuropsychological aspects. And we have had Dr. Idro, who is a neurologist in Uganda. Paul Bangirana. He came as a research assistant, has now grown to become also a neuropsychologist, and this is myself. So as the end, I want to really to thank all the collaborators. Here in the university, we've had people like Jim Hodges, Sarah Cusick, who has Jim of course you probably know him. He has done most of the analysis, and Sarah has joined and is working on is the PI on the iron studies which we are doing in Uganda. From Michigan, we're working with Judy Bass and Bruno Giordani, who are helping with the neuropsychological aspects. And in Makerere, we have also recruited other faculty to work with us, Ezekiel Mopere and Olen Nakasuja. I also want to acknowledge the funding agencies, the many funding agencies that have funded our studies through the years. And also acknowledge the key institutions, the Department of Pediatrics of UMN, who have really always helped us with funding, helped us with bridge funding, supported us whenever we needed, and the Departments of Pediatrics and Psychiatry at Makerere University, who have given us the space to work with all the children, and the caregivers who have been part of our studies throughout the years. And this is the team. As I speak now, we are now, and this part of the team, we are actually now, the team is now actually 83 people strong, who are employed full time on the collaboration. Yes. So, I thank you. Your questions?
coordinating the difference between the pathology and the psychopathology, if you will. The second question that I have for you is more of an observation, and that is something that, for those in the audience who are not aware of it, the first, as far as I know, one of the first observations about iron deficiency and the problems with dying from malaria came from Dr. John Murray, who was an adult cardiologist here. He and his family studied this and pointed this out in the Lancet a long time ago. I can't remember, 30, 40 years ago. And then the final point I want to ask is off the subject, but when mosquitoes transmit malaria, is there any evidence that you're aware of that they transmit something like Ebola? Because I'm worried about the mosquitoes in Texas. If they take blood and somebody is viremic, you would think that the next person they bit might get the virus. Is there any evidence or anybody looked at that?
Okay, so I have to repeat the question for the sake of those who are watching on video. So the question number one was: what does the brain look like for those who have cerebral malaria? I will answer that one first. So first we saw that the pathology was mechanical, that the parasites sequester in the capillaries, block the capillaries, cause hypoxia, and then the patient goes into coma and probably death. And therefore, if you cut the brain, you should see a lot of parasites sequestered in the capillaries. But that has not really held. We have not done autopsies for our patients, but those that have been looked at have actually not consistently found that there's necessarily sequestration and in the brain. Okay. Right now, we think probably it's probably more of an inflammatory response, an exaggerated inflammatory response that causes the coma. But nonetheless, we are looking at the fundus and seeing, you can sometimes see changes in the fundus. You can see retinal changes in the fundus that kind of point out to sequestration. And about, I think, 2/3 of the children who have CM actually have those changes, but not all of them. But interestingly, even children who have other forms of severe malaria, they say they also have those changes in the retina. We are in our present study right now, we are trying to do a fundoscopy for all the children and see whether we can find out where there are any changes. But there doesn't seem to be any gross changes in the brain per se. You know, some of them may have increased intracranial pressure from other reasons, but not because of the parastemia itself. We're also doing right now. We're also doing MRI and CT scans of a number of our children who have pathology to see what would happen. We think some of the pathology in the brain can be because of the symptoms of the convulsions rather than the malaria per se, but the effects of the malaria can be causing some of those symptoms in the brain. So there's nothing pathogonomic that you can see in the brain tissue if you did it. It's only for the athletes who have concussion and they have something which is obvious. I think it's more functional than necessarily grossly anatomical. The second question was probably an observation that yes. But the third question was, is there any relation? Can the mosquitoes also transmit Ebola? Of course, Ebola now is a big problem in Africa, in West Africa, not in East Africa. Actually, we have no Ebola in Uganda, right, as I speak. I'm not aware of. I don't know whether Michan can help me, but I'm not aware of any mechanism by which mosquitoes could transmit Ebola. Ebola is more of hygiene thing. I mean, it is more of it's more of if you get in contact with the fluids, with the tissues of someone who is sick.
But they are viremic, are they not?
So I don't know if, I don't know enough about Ebola to say it, but I'm sure they would be viremic. But there's lots of viral diseases where patients are viremic and yet they are not transmitted by the mosquito. And then others, like all the arboviruses.
If I hadn't read the newspaper today, I wouldn't have asked that question.
Right. Yeah. So I don't think you have to worry about that with Ebola, like as with many other viruses. And just a sort of side note of Bob's comments on the pathology. So I'd add a little bit of nuance to that to say that most people do think that sequestration, I mean, if you do autopsies, which the Malawi group has done, about 70%, as Bob said, will have this phenomenon known as sequestration. So it happens. It doesn't really happen in anything else. So kids who have that, it only happens in cerebral malaria. The question has been, is that an end effect of other things that are causing the problems, or is it actually causing the problem itself? And that's not what's known.
So what percent of the children who have cerebral malaria that you treat are actually completely cleared of the parasite?
When we treat them, we actually clear the parastemia. So by the time they leave us, they are clear of parastemia. You can, but the issue is that I think the effect that they get is because of the initial insult they get from the parastemia. But the treatment is able to clear the parastemia. I mean, sometimes they come too late after they've already gotten the problem. So even if you clear the parastemia, you cannot reverse what damage has already taken place.
So I'm just interested because the children who had other forms of malaria also had different, but had neurological deficit as well, attention deficit disorder. So I was just curious when you were doing the follow-up on them, how many were actually completely cleared of the parasite, or you just couldn't detect it when it came back?
No, in most cases we clear the parasite. We do a blood test before we discharge them, and so by the time they go home, they are clear of parasitemia. Yes.
Thanks for that nice talk, and congratulations on all this work that you've put together over these years. It's very impressive. Just a real quick question. I'm interested in the cytokine storm and high-grade parasitemia. And you mentioned it briefly as one of the parameters that you're looking at. But I wondered, are there one or two or three cytokines really stand out when you interrogate this by microarray or other assays that are really seem to be the major players in these kids with high-grade parasitemia or cerebral malaria. And as an extension, I'm wondering if there might be some role in the future for monoclonal antibodies that block some of these agents. I just wonder if you have any data on that. Is it TNF? Is it interferon gamma? Or do you have that answer yet?
Yes. So the question was that are there any cytokines, specific cytokines that stand out in these patients who have severe malaria? And the question actually is yes. There are the number of cytokines that we have isolated that actually stand out. Maybe since Chan is here, I'll ask him to answer that question because he has been doing most of the analysis himself from here.
So, yeah, the standout cytokine is TNF. That's
Yeah.
not just from our studies; it's from every study that's looked at it. We were the first group to look at it in the cerebrospinal fluid, and it's also elevated in the cerebrospinal fluid. And it's our study is the only study that's shown a relationship of any of these to outcomes. So elevated TNF alphas in our previous study and in the current study were related to neurologic deficits at 3 months and 6 months out. So, it is clearly important, and there's animal studies that also show, and they have their flaws because you can't do p-falciparum in animals, but they also show that TNF-alpha is important. Not only is it present, but it's actually important in pathogenesis of neurologic deficits. So a study was done, I think it was done with an antibody to TNF, I think it was etanercept, and it unfortunately showed the opposite of what one would like to show. So there was mortality wasn't changed, but the kids who received the monoclonal actually had more long-term neurologic deficits. So it kind of like set the whole monoclonal field back a while, and nobody knows exactly why. The theory was that maybe the monoclonal actually kept unbound TNF-alpha in the circulation longer, so it was keeping things around longer and allowing them to have an effect longer. And whether or not another form of a monoclonal to TNF would have a different effect, is open to question. So I think people are still thinking about that, but that one study sort of set back that area. The other cytokines that seem to be important are IL-1 beta, and then for severe malarial anemia, the ratio of TNF to IL-10 is very important. So if you have a high TNF to IL-10 ratio, you're much more likely to be anemic.
Someone along the way must have done some studies at some point of high-dose steroids.
Yes, and unfortunately, that was also a disaster.
It's actually a disaster because if you give steroid, it actually makes the malaria worse. They did actually a randomized control trial giving steroids and didn't improve the outcome.
There were higher mortality,
Yes.
so that they are contraindicated in
Yes.
cerebral malaria. Even though the studies by Terry Taylor's group in Malawi really seem to point to increased intracranial pressure as the kind of pre-death event in children who die, and she's got MRIs and stuff. I mean, it's very nice study. But neither steroids nor mannitol have been effective. Mannitol in children was not effective, and mannitol in adults actually also increased mortality. So this is unfortunately a disease where every adjunctive therapy tried to date has either been ineffective or has made things worse. So reason for trying to understand things better.
But Kenny, excuse me, before you sit down, nobody has done thin slices of brain to see in these kids that die with this as to what it is. And again, I referenced the national.
Yeah, so what I was saying, maybe it wasn't clear, was that the Malawi group has done those studies on many children. What they found was that the hallmark finding is sequestration, so parasite sequestration with blockage of postcapillary venules.
Are they anoxic? Is that?
These are gross autopsy studies. I don't know if they're able to say if they're anoxic. What they can say is that there's this blockage of the postcapillary venules, that you have ring hemorrhages, but you don't have like focal areas of necrosis. You don't have extravasation of white cells into the CSF. You don't have or into the brain. You don't have the parasite invading into the brain. So you just have this blockage and a blockage without focal areas of necrosis.
This would seem to me that this would be one of the things that would give you a clue as to what's going on. I mean, I was really impressed, and guess I'd either forgotten it or never knew it, that these kids wake up and walk off home.
Yeah, so the thought is that that obstruction is reversible, and so the one area that seems promising is agents that can prevent sequestration, and so that's something that there's a derivative of heparin that one group is trying to administer that will not increase your bleeding risk, but would decrease the risk of the parasite. So to decrease sequestration, you want to try and decrease the risk of the parasite attaching to the endothelium, and that's what they're trying to do with this. And that's one adjunctive therapy that's maybe promising.
I'm not a radiologist, obviously, but those kind of studies that they show what areas of the brain are being active and so forth and so on would seem to fit to have an application here in terms of during the acute clinical part of it.
Yeah, I mean, the Malawi group has MRIs. We don't, because there are MRIs in Kampala, but they're not at the hospital, so we can't transport these very sick kids. But they don't have functional MRI, and they don't have PET scan, and that's probably not going to happen, unfortunately. So it would be a dream. Bob and I would love to have that on site, but because you're right, then you could really get at what's happening physiologically.
Yes.
For the interesting talk. I'm interested in the robust research that's being carried out in Uganda, because as research in Africa can be very challenging. I think it goes beyond just having great collaborators and a passion for the work. So what were some of the real obstacles you had to overcome to do this?
So the question is, what are some of the obstacles we need to overcome? Many obstacles, many obstacles. One that I think are probably very hard, the infrastructure, the things to use are not necessarily there. So you want a CT scan, you can't get a CT scan. You want to do even simple things like a complete blood count can be a challenge to do. Getting a good parasite count can be a good challenge. So those are the obstacles that the facilities, the equipment you need for good research is not there, and oftentimes you've had actually to either import, to borrow, to loan, so we work around it, but that's one of the challenges. The second challenge, of course, is that the numbers are too big, and so sometimes there's a fine line between doing research, you want to get data, or just doing care. Because sometimes because the numbers are very big, you want to put your effort just to do care. And yet research requirements are kind of more stringent. You have to record everything, you have to spend more time with the patients, you have to follow up more closely. And so there can be that conflict between the research that you need to provide for the patient and the care. Okay. And because the research gives more care, sometimes there's a bit of coercion. Patients just want to come for the research. They don't really make a good informed consent. The other issues are the other issues are the issues of collaboration. Really, we have about 5 IRBs. You have the IRB here, you have the IRB in Makerere, the IRB somewhere else, and so the demands, the requirements, the expectations might be different. The other big thing I want to talk about is the technology. The communication can be a challenge. Here we take internet for granted, but there internet speeds are very slow. You cannot do good conference calls, getting emails. Sometimes they don't even open, so it can be a big challenge. So there are several challenges that we face, but they're not insurmountable. You can always work around it, as we have shown this time. Yes.
Great. Thank you very much, Bob.
Yes.
Thank you very much.
Thank you.